This is a self-learning module on cyanotic heart defects. My name is Rahan. I'm a pediatric cardiologist at St. Michael's Hospital. I have no conflicts to disclose. The end-of-week objective is to describe the pathophysiology and consequence of cyanotic heart defects. In the last module, we discussed an approach to cyanosis. In this module, we'll talk specifically about cyanotic heart defects. By the end of this module, you should be able to describe the normal cardiac anatomy and physiology, identify the pathophysiology and consequence of cyanotic heart defects with key examples, and name common cyanotic heart defects. Let's first talk about normal cardiac anatomy. So here is a 4-chamber heart with the apex slightly to the left. Blood will come from the SCC and IVC into the right atrium and into the right ventricle where it's pumped to the lungs to pick up oxygen. It picks up oxygen, comes back through the left atrium into the left ventricle, and then goes out the aorta and is distributed around the body. Cyanotic heart defects cause cyanosis by providing a way for deoxygenated blood returning from the body to bypass the lungs and re-enter the systemic circulation again. It does this through 3 overlapping mechanisms. One is mixing, where deoxygenated blood and fully oxygenated blood from the lungs is able to mix inside the heart. There can also be complete separation of the systemic and pulmonary circulations so that deoxygenated blood from the body is able to then go back into the body again. You can also have a right to left shunt, where blood goes through from the right to left side of the heart through a shunt due to obstruction or issues that prevent blood from going out to the lungs. We'll discuss each of these individually. Let's start with the most common. Tetralogy of Fallot is the most common cyanotic heart defect, comprising 10% of all congenital heart disease. The tetralogy in tetralogy of Fallot are large VSD, pulmonary stenosis, overriding aorta, and right ventricular hypertrophy. But it's actually one thing, and the one thing is the malalignment of the ventricular septum. As you see on the diagram, the top part of the ventricular septum, called the outlet septum, is deviated anteriorly. That, because the 2 ends of the ventricular septum don't meet, you have a hole, the VSD. Because the anterior part of the outlet septum is anterior, it causes crowding underneath the pulmonary valve, and so you have subpulmonary stenosis that can extend all the way through. The malalignment also pulls the aorta anterior, and so you have the aorta that overrides the ventricular septum. Because of pulmonary stenosis, the right ventricle has to pump under higher pressure, so you then develop right ventricular hypertrophy. This is tetralogy of Fallot. Now, how cyanotic you are depends entirely on how much pulmonary stenosis you have. If you only have mild pulmonary stenosis, it may still be easier for the blood to go left to right through the VSD and go to the pulmonary circulation. But if you have severe pulmonary stenosis, then it's easier for the blood to go right to left across the VSD and re-enter the systemic circulation. Children with tetralogy of Fallot may also have hypercyanotic episodes called TET spells, where the ring of muscle below the pulmonary valve suddenly spasms and the pulmonary stenosis becomes much worse. This can cause profound cyanosis and can lead to syncope and sudden death. Children having a TET spell may instinctively squat, which increases their systemic vascular resistance and reverse the direction of shunt across the VSD. The clinical findings in tetralogy of Fallot are a large systolic ejection murmur at the left upper sternal border caused by pulmonary stenosis, and variable oxygen saturations depending on the degree of pulmonary stenosis. The ECG will show right axis deviation, right ventricular hypertrophy. The chest X-ray may show a boot-shaped heart due to an upturned apex caused by right ventricular hypertrophy and a small main pulmonary artery. Management consists of relieving the obstruction and closing the VSD. So here we have closed the VSD with a patch and enlarged the right ventricular outflow tract. Transposition of the great arteries is the next most common cyanotic heart defect, comprising 5% of all congenital heart disease. Here, there's discordance between the connection of the ventricles to the great arteries, so that the right ventricle connects to the aorta and the left ventricle connects to the pulmonary artery. So deoxygenated blood comes from the SVC and IVC into the right atrium, right ventricle, and goes out the aorta to circulate around the body again. whereas fully oxygenated blood from the lungs comes into the left atrium, left ventricle, and goes back out into the lungs again. So with no intervention, this baby will be very blue soon after birth. There's complete separation of the pulmonary and systemic circulation. The chest x-ray may show a typical egg on a string pattern. Because the aorta is directly in front of the pulmonary artery, the upper mediastinum will appear narrowed. Truncus arteriosus is a rare congenital cardiac defect, but a good example of our next type of cyanotic heart disease, a mixing lesion. Here, there's a common arterial trunk that failed to divide into separate aorta and pulmonary arteries. So deoxygenated blood from the right side of the heart and fully oxygenated blood from the left side of the heart both enter the common arterial trunk, and the total oxygen saturation is somewhere in between the two. From there, the blood has the choice of either going out the aorta to the rest of the body, out the pulmonary arteries to the lungs, and to the coronary arteries to perfuse the myocardium. Soon after birth, your pulmonary vascular resistance will fall and becomes much easier for the blood to go to the lungs than the rest of the body, and you can develop symptoms of congestive heart failure, such as dyspnea and decreased exercise tolerance. When the blood goes around the body, it's deoxygenated. But as your pulmonary vascular resistance falls and more blood goes to the lungs, then there's more blood coming back from the lungs, and your oxygen saturation may actually go up. But if you do a proper hyperoxia test, you would still fail. As more blood goes to the lungs, there's less blood available to go to the coronary arteries, and you can have coronary ischemia due to steel and develop ischemic cardiomyopathy. Typical chest x-ray finding is cardiomegaly, big heart, and increased pulmonary vascular markings. Corrective surgery includes separating the two circulations. So here we have an RV to PA conduit, an artificial tube that takes the place of the main pulmonary artery. Then the truncal valve and the main trunk is then used as the new aorta, and the VSD is closed. So here you can see the separation of the two circuits. Eisenmenger syndrome is another example of right to left shunting. This occurs when you have a long-standing left to right shunt, develop pulmonary hypertension, and there's a reversal of flow. Let's take an example of a large VSD. Initially, the VSD will shunt left to right because the pulmonary vascular resistance is lower than the systemic vascular resistance. Over time, this can lead to pulmonary hypertension, where the pulmonary vascular resistance goes up. And if the pulmonary vascular resistance goes higher than the systemic vascular resistance, then you can have reversed flow, or right to left shunt across the VSD and cyanosis. Because the blood is bypassing the lungs, typically you will have dark lung fields on a chest x-ray. So we have reviewed the various mechanisms of cyanotic heart defects. You can have mixing lesions where deoxygenated blood from the body and fully oxygenated blood from the lungs mix inside the heart. This can occur at the level of the great arteries, such as truncus arteriosus, at the level of the ventricles, such as tricuspid atresia and other single ventricles, and at the level of the atria, such as total anomalous pulmonary venous connection. You can have complete separation of the systemic and pulmonary circulations, such as in transposition of the great arteries. And you can have a right to left shunt due to obstruction to pulmonary blood flow. This can be anatomic, such as tetralogy of Fallot, pulmonary stenosis, pulmonary atresia, or Epstein's anomaly, or it can be physiologic, such as Eisenmenger syndrome. Now, these are a lot of cardiac diseases to keep track of. So one easy way to remember the cyanotic heart defects is to remember the 5 T's. 1, one great artery, truncus arteriosus. 2, two great arteries in parallel, transposition of the great arteries. 3, tricuspid atresia and other single ventricles. 4, tetralogy of Fallot. And 5, total anomalous pulmonary venous connection, TAPVC. There are a couple more we didn't list here. 2 P's and 2 E's. Pulmonary stenosis, pulmonary atresia, Epstein's anomaly, and Eisenmenger syndrome. These are all causes of right to left shunting. So we've described the normal cardiac anatomy and physiology, talked about the pathophysiology and consequences of cyanotic heart defects with some examples, and provided the names of some common cyanotic heart defects. Thank you.